Thank you for joining our Debbie's Dream Foundation webinar series. Today's webinar is featuring Dr. Jeremy Davis. I'm Jackie Bello, Programs Manager for Debbie's Dream Foundation, and I'll be moderating today's webinar. I'd like to thank our sponsors, title sponsor, Daiichi Sankyo, platinum sponsor, Bristol Myers Squibb, gold sponsors, Astellas and Merck, silver sponsor, Lilly Oncology, and bronze sponsor, Genentech. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we will hear a presentation with Dr. Jeremy Davis. The presentation will be followed by a Q&A discussion. You can type your questions throughout the presentation into the chat section that appears on the webinar menu. We will address questions at the conclusion of the presentation as time allows. This year, nearly 30,000 Americans will be diagnosed with stomach cancer, and 11,000 will die. Stomach cancer is one of the leading causes of cancer deaths worldwide, with a dismal 5-year survival rate of between 20 to 30%, depending on the country. Many patients are asymptomatic during the early stages of stomach cancer, leading to a late diagnosis. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at debbiesdream.org. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April of 2008. She had no risk factors and only vague symptoms. At the time, she was told her chance of being alive in 5 years was only 4%. She endured harsh chemo regimens and targeted treatments and experienced many recurrences over 9.5 years. Unfortunately, Debbie passed away on December 23rd of 2017 at the age of 50 after a 9.5-year battle with cancer. She dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Debbie founded DDF in April of 2009. As an organization, we will continue her important work and legacy. In a few short years, DDF has achieved many great milestones. We have 34 chapters across the US, including Canada and Germany. Our PrEP program helps patients, their families, and caregivers match a survivor and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We have also provided $1 million in research grants to date. In addition to research funding, we also advocate at a national level. This year, our Capitol Hill Advocacy Day was a huge success. We hosted 115 advocates and had 230 meetings on the Hill, making this our largest and most successful turnout yet. Due to the efforts of the foundation, our partners, and our dedicated advocates, we help secure continued funding for stomach cancer research. Here you can see some of our upcoming events. To learn more, visit our website under the heading Events. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday, 8:30 a.m. to 5 p.m. Eastern Time. Also on this slide are important phone numbers and email addresses you can use to contact our office and staff. We will now begin the presentation with Dr. Jeremy Davis. Dr. Davis is a surgical oncologist and associate research physician in the Center for Cancer Research, part of the National Cancer Institute, the National Institute of Health. He received advanced training in cancer research as a fellow at the National Cancer Institute and is surgical oncology at Memorial Sloan Kettering Cancer Center. And is board certified in both complex general surgery oncology and general surgery. He currently serves as Surgeon-in-Chief of America's Research Hospital, the NIH Clinical Center. Dr. Davis's primary research is gastric adenocarcinoma with specific focus on CDH1-driven gastric cancer and the hereditary diffuse gastric cancer syndrome. He's a principal investigator of several active clinical trials being conducted at NIH. We'd like to thank Dr. Davis for taking time out of his schedule today. Now, Dr. Davis, I will turn the presentation over to you.
Thank you.
All right. You should have mouse control now.
Okay, well, that was a great introduction. Thank you very much. And thanks to Debbie's Dream for having me here today. Let's see if I can advance the slide.
I see your mouse moving.
Oh, the joys of technology.
I know. Everyone's experienced it now. There we go.
There we go. Okay. Well, I'm going to talk a little bit about some, topics that I think will cover a lot of the most frequently asked questions about stomach cancer. Just to let you know, this picture is of the NIH Clinical Center, which sits on the NIH campus in Bethesda, Maryland. So I have no disclosures. And the topics that I'm going to try to cover during this are a few listed here. What is gastric cancer? What are some known risk factors? How do we stage gastric cancer and provide prognosis? A little bit about surgical treatment, therapy for advanced cancer, and then a little bit on genetic testing for hereditary gastric cancer. And I'm purposely not going to go into a lot of detail on some of these because it might make for a more discussion later. So I'm going to start off with a little trivia. So the guy on the left is John Wayne, and the guy on the right is Napoleon Bonaparte. And so what do they have in common? Well, the answer is that they both died of stomach cancer, or they both had stomach cancer. And in Napoleon Bonaparte's case, there's questions that have surfaced about whether or not he may have even had a hereditary form of stomach cancer. But certainly that's not proven because that was so long ago. So just a brief overview of stomach cancer. So gastric cancer may also be referred to as gastric adenocarcinoma. Adenocarcinoma just means that this cancer arises from the cells that line the stomach, so-called epithelium or epithelial tissue. And as you heard in the introduction, there will be nearly 30,000 cases of gastric cancer diagnosed this year and about 11,000 deaths. Now, worldwide, however, stomach cancer is very common, and it's actually the third leading cause of cancer death worldwide. And this graphic on the left just shows that when it comes to overall prognosis, unfortunately, stomach cancer is towards the bottom in terms of prognosis at 5 years. So what are the risk factors for stomach cancer? Well, the main ones that we know about are environmental, and we've known about this for probably almost 100 years, that diets rich with salt or high nitrate content, such as in preserved meats, is a risk factor. A major risk factor worldwide is Helicobacter pylori, which is a bacteria that basically lives in the lining of the stomach and causes chronic inflammation that leads to stomach cancer. We also know about tobacco use and obesity being general risk factors for a lot of cancers. There are genetic factors. We'll talk about the CDH1 gene mutation later, but there are some other cancer syndromes that are uncommon, but can also raise the risk for stomach cancer. And then there are a few other rare things, such as a condition known as pernicious anemia, or people that have had radiation to the stomach in the past that can raise their risk of developing stomach cancer. Now, the good news is that in the United States, the trend is down in terms of the incidence of gastric cancer each year. So you can see on the far left, starting in 1992, this rate is per 100,000 people. And as we move to the right, both the rate of new cases and the death rate from gastric cancer has continued to decline. And this is largely due to identification of H. pylori as a treatment or as a cause of gastric cancer and our ability to eradicate H. pylori. Now, There are two main types of gastric cancer, or specifically gastric adenocarcinoma, and this is based on what it looks like under the microscope. So the intestinal type here on the left is the type that usually forms a mass, occurs lower down in the stomach, and is really related a lot to H. pylori, and is seen in older people, but in general is one of the reasons why we're seeing a decreased incidence of this cancer in the United States. Interestingly, there's this other type called diffuse type, which causes a diffuse thickening of the stomach. It most often arises in the upper part of the stomach and may, in fact, in a lot of cases that we're not aware of yet, have a genetic predisposition. It seems to be occurring more often these days in younger people, and its incidence is actually rising slightly. Now, how do we diagnose and how do we stage stomach cancer? Well, really, the primary way to do this is with an endoscopy. So this is a tube with a camera on the end that's inserted in your mouth, down your throat, into your stomach. And we do this, perform biopsies, and that's how we get the diagnosis. Now, once we have a diagnosis, we usually do something called staging because we want to know at what stage this cancer is. So we usually will perform a CT scan or a CAT scan, and this is a way to look at the organs inside the body. A PET scan might be used. This is a nuclear medicine scan where you basically get an injection of what's called a radiotracer that goes in, and it's labeled with glucose is labeled with a radioactive molecule that highlights areas of either inflammation or cancer, can also highlight infection. So it's not a perfect study, but it's helpful in some cases. The other thing that we do is a laparoscopy, and I'm going to talk about this a little bit later, but this is again helps us stage the tumor. I will mention briefly now endoscopic ultrasound. We use this in the United States, although I'm going to tell you that it's likely not as useful in the United States as compared to other areas of the world, such as Asia. So here's a diagram. This is kind of how things go when somebody gets diagnosed. So they get diagnosed with an endoscopy with a biopsy, and then 1, 2, or maybe all of these studies are done to help stage the cancer. So a brief mention of the endoscopic ultrasound. Again, I think it has limited utility, but you may see people that have undergone this. Endoscopic ultrasound, or EUS, is used to define the tumor stage, which is the T stage, which is basically the depth of invasion of the tumor. So over here on the right, you see this figure. The lining of the stomach is here, the outer wall of the stomach is here, and tumors usually start here at the top and invade down towards the outer layers. It can also assess lymph node status. But EUS is highly user dependent, and it's very helpful for very early stage stomach cancers, especially those that we think we might intervene on endoscopically. So for instance, our accuracy with EUS varies considerably. So a very early stage cancer, it can be accurate. But once you get to a T2 tumor, the range is quite variable, and T3 I would tell you is probably not very useful. So somebody's been diagnosed, they have staging studies. Now, what about laparoscopy? What is the role of laparoscopy? Well, laparoscopy is relatively unique to gastric cancer staging. You won't see this in a lot of other cancers like colon cancer or even pancreas cancer. It's not used in the way that it's used with stomach cancer. So why do we do laparoscopy? Well, laparoscopy is used to detect metastatic disease, meaning tumors that have spread beyond the stomach, which we can't detect on a CT scan or a PET scan because CAT scans and PET scans are not perfect. They have their own limitations. More importantly, long before people did laparoscopy, somebody might be diagnosed with stomach cancer, be taken to the operating room for a potentially curative operation, only to find that tumor had already spread beyond the stomach. And therefore, patients would be undergoing that kind of invasive surgery for no real benefit. And so we know that doing laparoscopy, if it's able to detect cancer that's spread beyond the stomach, it avoids us having to do a big incision on the stomach only to find that the tumor has spread. But more importantly these days, the addition of what we call peritoneal washings or peritoneal lavage, where we put fluid in the belly, wash it around, and suck it out and send it to the pathologist. They look at that fluid under the microscope. That's called cytologic examination. That allows us to identify any microscopic evidence of spread of tumor, which is going to allow us to select treatments better for patients. And it's important to know that unfortunately, even if we find microscopic evidence of cancer cells within that peritoneal fluid, unfortunately that does equate to stage 4 or metastatic cancer. And this table just shows you that on the left here, if you have a very early T-stage gastric cancer, the likelihood of finding cancer cells in that cytology is pretty low. But if your cancer stage or T stage is higher, that likelihood of finding cancer cells goes up. And you can see down here, AJCC is the staging system that we use. And you can see for stage 1, 2, and 3 tumors, that the likelihood of finding these cancer cells in the fluid does increase slightly as the cancer stage progresses. So here's the overall treatment paradigm. People are diagnosed, they're staged, including laparoscopy. If we find metastatic disease, then we want to initiate systemic therapy, meaning therapy through the IV, such as IV chemotherapy. But if that laparoscopy is negative, meaning we don't see evidence of metastatic disease, people go down a treatment pathway. And I will tell you that in the United States, we tend to use this treatment pathway here, meaning perioperative chemotherapy, meaning chemotherapy, then surgery or gastrectomy, and then some more chemotherapy afterwards. This side over here is based on a trial that was run around the late 90s, early 2000s, and it's really based on surgery first and then some chemo or radiation afterwards. We don't use this as much in the United States. Now, I apologize, my attempt at animation failed miserably here. So treatment is generally according to stage. So if you have an early stage tumor, which I would tell you is basically a stage 1 tumor, your treatment, and now this is where the animation is horrible, your treatment is primarily surgery. So early stage tumors, very early T stage, we can take patients straight to surgery. And oftentimes they don't require any chemotherapy after surgery. Now, as I move through the animation, if you have a middle stage tumor, meaning this is kind of a stage 2 or 3 tumor, kind of middle of the road, not an advanced stage, we usually do this perioperative chemotherapy. So some chemotherapy followed by surgery to remove the tumor, and then some more chemotherapy. And then if we have a late stage tumor, meaning stage 4 or advanced cancer, usually chemotherapy is the primary treatment modality. And I could have written immunotherapy here too, and we'll talk about that briefly later. So we treat the tumors according to their stage. Now, people ask this quite often, what is the survival? What's their prognosis related to stage? And as with most cancers, as stage increases, so from 1 to 2 to 3 to 4, unfortunately, the likelihood of survival at 5 years after diagnosis decreases. So surgery for gastric cancer involves removing part or all of the stomach. I will tell you that the approach does not matter as much as the surgeon's experience operating on the stomach. And nowadays, surgery for stomach cancer is not super common because it's not as common a cancer as you saw in the early slides. So open versus laparoscopic or robotic surgery is what I mean by the approach. We remove lymph nodes as part of the operation, and this adds to our information related to staging and helps us determine what kind of treatment people may need after surgery. And the most common types of operations you will hear of are things like total gastrectomy, which means complete removal of the stomach with what's called a Roux-en-Y reconstruction. You may hear of a subtotal gastrectomy, which means we leave just a little bit of the stomach. And you might hear about a distal gastrectomy or an antrectomy with a Billroth 2 reconstruction. And this is not too gross of a picture, but a picture of what the stomach looks like when it's taken out of someone. So what's life like after gastrectomy? Well, there are these things called post-gastrectomy syndromes, and I will tell you that they can or often will occur. And they're really associated most commonly with total gastrectomy, but can be associated with partial gastrectomies. So for instance, here on the left, you can see here's the stomach, the esophagus comes down, we cut right here, take out the stomach, and we have to put people back together. And this is what's called the Roux-en-Y reconstruction. And this can lead to a lot of life-altering issues after surgery. So for example, people might talk about issues with bile reflux or dumping syndrome. You might hear about delayed gastric emptying. This is quite common after partial gastrectomy. But overall, patients can live without a stomach, but they will experience a new normal. Life after gastrectomy is different. And nutrition is going to be key because your stomach obviously plays an important role. So dietary counseling is always a necessity. So now I just want to touch on this idea of chemotherapy before and after surgery, this so-called perioperative approach to treatment. So chemotherapy is often given before and again after surgery based on this study that I'm going to show you right here. It was published, if I remember correctly, in 2006. And what it showed is that people in the red line who got chemotherapy before and after surgery versus people who just got surgery alone, which was really what we did back in the late 80s, early 90s. The people in the red line lived longer or did better than the people who did surgery without any chemotherapy. So this is what led to us making this the standard for treatment, at least in the United States. Now, what about targeted therapy or precision medicine, which you hear a lot about? This is the concept that the tumor has unique changes that make it susceptible to drugs that target only cells or cancer cells that have that specific change. So an example here is a drug called trastuzumab, which targets HER2, which is a molecule that's expressed or it can be overexpressed on stomach cancers. And it's approved for the treatment of advanced gastric cancers that express this target or this molecule. In this study that was done called the TOGA trial, about 22% of stomach cancers in this study expressed enough HER2 to make them eligible for the treatment with this drug. So basically about 1 in 5 patients with stomach cancer might be eligible to receive this drug. And so this is a targeted therapy because when you give trastuzumab, it's supposed to only target and treat cancer cells or cells that express this molecule HER2. So you can see in this study, the red line is the patients who got trastuzumab plus chemotherapy. And because this line is a little higher and extends out a little longer, you can see that those patients did better than the patients who just got chemotherapy alone. So this is the idea that we can start to take advantage of the specific changes in the tumor. Now, a brief mention about immunotherapy. Immunotherapy, as we know it right now, really applies to a class of drugs called immune checkpoint inhibitors. There are lots of ways to activate the immune system, but I just broadly speaking for this topic, we're talking about drugs that you've heard about on the news like nivolumab or Opdivo or pembrolizumab, also called Keytruda. These are drugs that basically stimulate the immune system to attack cancer. They activate your own immune system. It's not like giving a drug that actually kills the tumor. These drugs don't do anything to the tumor. They actually stimulate your immune cells. Now, in the United States, the approval of these drugs in gastric cancer are limited to a few scenarios. One is for tumors that express something called microsatellite instability, meaning they have this characteristic that's also referred to as MSI, basically unique properties that make them potentially sensitive to immunotherapy. Also, tumors that express a high amount of this molecule called PD-L1. Now we're learning a lot more about this in that you can express, your tumor can express a little bit of PD-L1, but if it expresses a lot of PD-L1, that's better, meaning more sensitive to the immunotherapy. And then another more recent finding is that tumors that have what's called a high tumor mutation burden, meaning tumors that are really kind of gnarly and have a lot of genetic mutations, may be more susceptible to immunotherapy. So immunotherapy is exciting. It's probably applicable to a subset or a fraction of patients with stomach cancer, and unfortunately still not widely applicable like many of the targeted therapies. So a brief mention about gastric cancer syndromes. This does constitute a lot of my work. I'm going to mention just briefly probably the most relevant one or the most frequent one that we see, which is hereditary diffuse gastric cancer due to this gene mutation in a gene referred to as CDH1. Hereditary diffuse gastric cancer is really characterized by a few things. One is diffuse gastric cancer seen early in people in your family. These are cancers that are characterized by these things called signet ring cells. We also see these families have lobular breast cancer, and they may even have people in the family with cleft lip or palate. And we see this not in skipping generations, but in every generation. That refers to autosomal dominant. And basically what we see most often is a mutation in this gene, this CDH1 gene, and we see it in about 20 to 40% of families that appear to have this cancer syndrome. Now, not all families will have a CDH1 mutation, and when we look for other mutations, we don't often find one, but one that we've been finding more recently is CTNNA1, which really has functions very similar to CDH1, and they interact a lot in cells. The problem is that advanced cancer diagnosis is also commonly associated with peritoneal carcinomatosis or spread to the abdominal cavity in hereditary diffuse gastric cancer, just like it is in sporadic or the non-hereditary form. So people will ask, well, how do I know if I need genetic testing for my stomach cancer? Well, it's recommended when one of the following criteria have been met, and we have to confirm these diagnoses in a family. And I'm sorry that it doesn't display properly, but these first three criteria are family criteria, meaning if we see 2 or more cases of stomach cancer in a family, and at least one of them is this diffuse type gastric cancer, that raises a flag. If we see 1 or more cases of diffuse gastric cancer in a family and at least 1 case of lobular breast cancer, that raises another red flag. Or if we see 2 or more cases of lobular breast cancer in women in a family that are less than 50 years old when they were diagnosed, those are all criteria for doing genetic testing. And for some reason, oh, there it goes. Now, there are also some individual criteria. If someone comes into my office and is diagnosed with a diffuse gastric cancer and they're younger than age 50, we should definitely do genetic testing. If somebody has diffuse gastric cancer, regardless of their age, and they have had cleft lip or palate themselves or a first-degree relative, then we should test them. Anybody who has a personal history of both diffuse gastric cancer and lobular breast cancer, or someone with a personal history of bilateral lobular breast cancer. These are all criteria for doing genetic testing, specifically looking for CDH1. So I just want to summarize this part, and then we probably can move to questions. But gastric cancer is uncommon in the United States, but it's certainly not uncommon worldwide. It's very common throughout the world. And gastric cancer, unfortunately, often presents at later stages, especially stage 4. Surgery and chemotherapy are the most common treatment, and especially surgery is important for those patients with either early or middle stage tumors. As I mentioned, immunotherapy is promising, but currently helpful in a fraction of patients, and certainly people would like to expand that to everyone. Hereditary gastric cancer is uncommon, but certainly should be considered in families with a history of lobular breast cancer and diffuse gastric cancer. So with that, I thank you for your time, and I'll turn it back over.
First question we have is, I already had a gastrectomy. I'll probably always be fearful of my cancer coming back. Should I watch for specific signs or symptoms that indicate a recurrence?
That's a good question. I think anybody who's had a gastrectomy might be more in tune to certain signs or symptoms, specifically related to a tumor recurrence in the stomach, or let's say in the esophagus where the intestines may have been sewn back in. So some people might experience difficulty swallowing, or some pain with swallowing. I would say that's not super common. But in general, it's one of the things that you might look out for, ask your doctor about. The truth is, a lot of recurrences are often picked up on surveillance scans, like CT scans, or can be picked up once in a while with tumor markers, although tumor markers aren't perfect, but these are blood tests that your doctor might get to look for evidence that the cancer might have come back. So hopefully that answers the question, but the symptom part of it, it's tough because there aren't any very specific symptoms that I would advocate that you look out for.
Okay. After surgery, what follow-up tests will I need and how often will I need them?
So if you're having surgery for stomach cancer that, let's say, you've either gotten chemotherapy for or your doctor plans on giving you chemotherapy for, the follow-up is pretty standard out there, and that is, after surgery, you'll probably follow up with the surgeon, within a few weeks or a month after surgery. But your oncologist or whoever may be treating you with chemotherapy is going to see you on a regular basis, and after you finish chemotherapy, you're probably going to see them every 3 months, and you're probably going to see them every 3 to 4 months for at least a couple of years. And during those visits, you'll have blood work done, and you'll probably have some form of scan, whether it's a CT scan or occasionally a PET scan. But that's how your doctor is going to keep an eye on things and be watching out for any problems or recurrences.
Okay, next question is, what does it feel like after a TG? Is there an empty feeling in the abdomen? How about hunger? Is that still present?
That's a great question. I can only tell you from what my patients tell me because I still have my stomach. But, after a total gastrectomy, people tell me that they oftentimes don't feel hungry, that they sometimes have to remind themselves to eat. I'm not so sure they complain of an empty feeling, but it's certainly curious that a lot of people say, I just don't feel the same kind of hunger that I
Hmm.
used to feel before.
Okay. After surgery, um, sorry, no. What long-term side effects or late effects are possible after surgery?
Yeah, it's a great question. So, surgery can have some late effects, and I usually break them up into things that are surgical or technical and those that are related to the function of your GI tract. So, for instance, from a surgery standpoint, anytime a surgeon has been in your belly, and for instance, I've had my appendix out, so I qualify. You can have scar tissue, and you can have scar tissue that can lead to something called a bowel obstruction. Now, after a gastrectomy, especially a total gastrectomy, you're also at risk for something called an internal hernia, very rare, but also basically presents as a bowel obstruction. So a bowel obstruction would make you nauseated, you'd have pain, and you'd probably start vomiting. Now, the other things that are not related to the surgery necessarily itself, but just the fact that maybe you don't have a stomach anymore or you don't have most of your stomach, these are all the things that are dietary related and the things that you hear about, like dumping syndrome or bile reflux and things like that. Now, the good news is those things are uncommon. Dumping especially is related exactly to what you put in your mouth. And so what I tell people is that our dietitian gives people a lot of good advice. If you put the right stuff in your mouth, the likelihood of having dumping syndrome should be pretty low. But those are late effects, and I think a lot of those late effects go away with time. Although the surgical issues related to a bowel obstruction, in theory, you're at risk for the rest of your life. The good news is those are exquisitely rare also.
Okay. Next question. How can I prepare for my first chemotherapy session?
That's a good question too. I think, chemotherapy is one of those things where it's almost like surgery, where if you tell somebody what to expect, it's hard to really understand until you actually do it. And one of the things about chemotherapy is to try to go in with a, a positive attitude, because everybody's going to respond to chemotherapy differently. And so you may talk to people or hear stuff or read stuff on Facebook. It doesn't mean that it's going to happen to you. But when you go in for chemotherapy, remember that sometimes the actual infusion of the chemotherapy is not too problematic, that you might actually get the chemotherapy and not feel horrible. Unfortunately, some of those feelings can come a day or two later. And your oncologist will tell you about those and warn you about those, and try to prepare you for some of those things. But I think going in for the chemotherapy sometimes can be very anxiety provoking. And the good news is that you're not going to go in and usually feel anything horribly on the day of the chemotherapy treatment. And that should be a little bit reassuring for people, although all chemotherapies are not the same. Some chemotherapy regimens are different. So that's why you have to talk to your oncologist about what am I getting and how should it make me feel.
Okay, great. Next question. Does insurance cover genetic testing?
So it's a good question. I think some insurance companies will. The good news is that genetic testing costs have come down considerably in the last couple of years. I know just in the time that I've been here at the NIH, the cost to the patient for genetic testing has gone from a couple $100 easily down to, in some cases, $50. So depending on your insurance, and if your insurance, doesn't want to cover it, or you don't want to deal with your insurance company, the cost out of pocket these days is getting better. It's not perfect, and in some cases it still can cost a couple $100 depending on what kind of genetic testing. But that's why you should always go to a good genetic counselor. They can oftentimes help you with that process. They can guide you and look for resources where the cost might be offset.
What genetic testing should I ask for? Is there a specific type?
No, so if, let's say, you're considering, or your doctor is considering genetic testing, and remember, it's not about whether or not you think you need it or want it. You need to talk to your doctor about it, and oftentimes you need to meet with a genetic counselor. But let's say your doctor or your genetic counselor think that it's necessary. If you have stomach cancer, by and large, we still will advocate for what's called a panel test, which tests for a panel of genes that can cause or be related to stomach cancer. What I wouldn't advocate for is if you're in a family with no known genetic mutation, you don't want to go and just get tested for one gene mutation, or your doctor probably wouldn't do that, I should say. You'll get a panel. Now, on the other hand, if I have somebody that comes to me and says, well, my brother has a CDH1 mutation and my grandfather has a CDH, then we're just going to test you for that CDH1 mutation. We're not going to do the whole panel. So it really kind of depends on the situation.
Okay. Another question related to genetic testing. I have a history of stomach cancer in my family. I want to get my kids tested early. My son is 11 years old, but genetic testing is not approved. What can I do, or what can my doctor do to get him tested?
Yeah, it's not that the genetic testing's not approved. I would suggest that it's probably not necessary.
Okay.
Here's why. An 11-year-old, if you decided to test them, and as a parent, that's your choice. And if somebody wants to do that, I'm sure they can do it. The real question is, what are you going to do with that information? And so as somebody who sees a lot of people with CDH1 mutations every day, if an 11-year-old came in with their parent and said, we have a CDH1 mutation, I would say, well, I'm not even sure I would advocate doing anything. Only if the child had like stomach issues and a lot of just kind of stomach upset might I suggest an endoscopy. But even then, I wouldn't be suggesting prophylactic gastrectomy or anything like that, for a couple reasons. Number one, we really don't want to take out anybody's stomach until they're old enough, they're done growing. So that's why the recommendations are not to even do a gastrectomy till people are 20 years old in patients with CDH1 mutations. Yes, have we seen people very young get stomach cancer in their early 20s? Absolutely. But there's a big risk benefit here about testing an 11-year-old and what you're going to do with that information. The other thing I think is important is that 11-year-olds, they're not they're not dumb. They know what's going on. But I'm not so sure an 11-year-old can really grasp the understanding of what's a genetic or a gene mutation and how that impacts my life. And I think that's also part of why we try not to test kids until they're older, as they approach 18 at least, so they're more mature and they can kind of process it and understand it, because frankly, there are 50-year-olds out there that get genetic testing and are overwhelmed with the information. Can you imagine an
Yeah.
11-year-old going, wait a minute, what does this mean? So I don't think anybody would say that it's not covered or not recommended, or they won't do it, or it's not allowed. It's that we generally don't recommend it,
Okay.
especially for CDH1. Now, granted, there's a lot we don't know. We're still learning more, and I'd be happy to, if this person wants more information, we're happy to engage.
Okay, great. For that person, question that came to mind for me, let's say they get genetic testing done and they have the gene, CDH1 gene, and they decide not to go about anything after that for the time being until the kid's older. Should they do any follow-up visits
Oh yeah.
to, okay.
Yeah, and so for full disclosure, we have patients, we have pediatric patients in our study, and they're here, and in the sense that we stay engaged and we're in contact, and it's kind of a conversation, because I joke with people a lot. If you have a 17-year-old girl, she's probably way more mature than the 19-year-old boy, right? So it just depends, and it's a conversation that we have to have, with the patient, with the family.
Okay. Next question. I had multiple people die in my family from stomach cancer. I tested negative 10 years ago for genetic testing.
Yeah.
Should I get retested? Is there new testing available?
What I would generally recommend is that we review, or somebody who knows what they're doing, review that genetic testing, kind of see what it showed, what did they do, what kind of analysis did they do. Yeah, some of the technology's changed a little bit over the years, and some of the genes on the panel may have changed. So it is true that years ago, some of the appropriate genes may not have been on that panel, and maybe now, like I mentioned, that ctNNA1 or alpha-catenin, if that wasn't on the panel, I would advocate testing for that, because there have been enough cases now of that mutation leading to stomach cancer that we would want to know that. So yeah, maybe repeat the panel, or maybe add in the genes that weren't on that panel, but I think it's worth discussing with your genetic counselor or somebody.
Great. Next question. How do I get a nutritionist on my treatment team?
That's hard, because they got to be there already. I mean, you
Mm,
know what, and this is another soapbox issue for me. I'm a surgeon. I think I do a good job in the operating room, but there's no way in heck that I could do what I do without a great dietitian. And so I think if you go somewhere and there's not a dietitian, and you need to ask about it. Okay, is there a dietitian? Are they available? How, what's their knowledge base, et cetera. The institution's got to have that for you, in the
mhm.
sense that I'm not so sure you're going to be able to find a dietitian just out there, on their own. They're usually attached to an institution like a hospital or an academic center. But I would be very wary about undergoing a major gastric operation, especially a total gastrectomy, without a dietitian. Because again, I think most of my patients would probably agree that I'm a nice guy, but they really need the dietitian to help them.
Yeah, of course. Another question. I have an oncologist. Who else should I recruit for my treatment team?
The oncologist, depending on your cancer stage, is going to be one of the key people if you're getting chemotherapy, especially. But I would argue that your surgeon is equally important. Now, in a lot of institutions, if the surgery is kind of straightforward and, et cetera, and then you just need chemotherapy afterwards, then the oncologist is going to be driving the boat. But I would see oncologist needs to be engaged, your surgeon, probably a gastroenterologist, and again, don't forget the dietitian. So again,
Mhm.
for example, here for me, we have a lot of people that don't necessarily exist at other institutions because of the cost, but we have a clinical pharmacist that helps with looking at drug absorption, and managing medications after gastrectomy, dietitian, genetic counselor, gastroenterologist. Obviously I'm the surgeon. So those are the key people. But I think oncologist, surgeon, gastroenterologist, those definitely.
Okay.
Registered dietitian, genetic
Mhm.
counselor, clinical pharmacist, those people would be super helpful, but I think it's going to be institution dependent.
Okay. Next question. I heard there's a new CDH1 target that is in developmental phase. Is this a promising study?
I'm not aware of that. I would love to know about it if somebody can share it with me, but I'm not aware of one.
Okay. Next question. Is there any new clinical trials studies coming up?
For gastric cancer in general?
Yes.
Okay, so good. So that's a great question. One resource that I think people have to use, although it's not a great resource in the sense that it's not super user friendly, but it's getting better, is clinicaltrials.gov. You
Mhm.
need to be able to go there, figure out how to type in stuff, et cetera. If you go on clinicaltrials.gov right now and look for stomach cancer or gastric cancer studies, you will find a variety of things. You'll find studies that are specific for stomach cancer, but then you'll find others that are for, let's say, solid tumors or gastrointestinal cancers in general. So they're like so-called basket trials. But in general, right now for stomach cancer, they'll fall into some classification or categories like immunotherapy trials. Then you'll have surgical trials, especially for
Mhm.
advanced cancer. So like we have a HIPEC trial here. We have another therapy for peritoneal metastasis. You'll see PIPAC out there, which I think is now being run at City of Hope and potentially out of Mayo in Florida. So clinicaltrials.gov, things come out on a routine basis. I'm expecting a clinical trial here to open in January, February. And so that's one of the reasons to just be, able to recognize that website's a great place to go. And those are where all clinical trials that are registered and regulated and kind of the ones that you would want to be
Mhm.
participating in are going to be housed.
Wonderful. There's also a link on Debbie's Dream to kind of, direct you to that site as well. And any questions, anyone can reach out to us as well. An
Perfect.
additional resource.
Yeah.
Okay, next question. Will chemotherapy or immunotherapy affect my ability to have kids in the future?
Good question. So there are certain chemotherapies that can, and we, especially when we are getting ready to embark on chemotherapy for folks who either don't have kids or are thinking about having more kids, we will talk about either egg preservation or sperm donation, things like that. Immunotherapy, we don't think so. The ovaries and the testes are kind of privileged sites in the body. We don't think that the immunotherapy would affect them at all. But there are certainly chemotherapies, and that's like oxaliplatin,
Hmm.
paclitaxel, docetaxel, those things. Yeah, and that would be something that you talk to your oncologist about.
Okay. Next question. I am 10 days away from surgery. How do I prepare mentally and physically?
Well, I think unfortunately 10 days away, there's not much you can do physically, but I'll tell you a few things that I would advocate you do. I tell all of my patients before surgery, it's kind of like running the New York City Marathon. You're not going to wake up one morning and just decide you're going to go run 26.2 miles. It makes no sense. You train for it first. So in advance of surgery, I tell people you don't need to get a gym membership. Just go out there and walk 30 minutes a day and walk briskly enough to kind of raise your heart rate. So 30 minutes, a minimum of daily activity, fast walking just to get your heart rate up is really good. Even 10 days before surgery, I think you can do that. And it can still be helpful. In terms of mental preparation, I think, listen, you just want to have your questions answered. If there are any outstanding questions you have, don't sit and ruminate over them. Don't lay awake in bed at night thinking, oh my God. Call your doctor's office. They should be responsive. They should say,
Mhm.
this is what we can answer for you. You should not show up on the morning of surgery and not know what's going to happen. I try to do my best, and then I have a team around me to do it also. This is what to expect. This is what's going to happen on the morning of surgery. This is what's going to happen the day after. This is how long you might expect to be in the hospital. You should have those questions answered. I think that'll relieve some of the psychological kind of or emotional kind of stress or anxiety.
Great. Um, Newly diagnosed, can you explain what the term second line therapy means?
Yeah. So when someone's diagnosed with any cancer, the first line treatment or the first treatment they get is usually the best that we're aware of, approved by the FDA. That's it. That's the top or first treatment. And then if you have to get another round of chemo, like let's say that chemo works, A year later, you need more chemo, that would be, and they switch to something else, that would be considered second-line chemotherapy. In general, second-line chemotherapy is still approved by the FDA, but it's approved to be used specifically after you get the first line, which is generally going to be considered more effective, better, whatever. Second line is not necessarily worse, but it may not be quite as effective as first line, and therefore it's called second line.
Okay, thank you. Next question. I'm not a candidate for surgery. What are my options?
So it depends. You know, everybody who has stomach cancer who's supposedly not a candidate for surgery should have very specific conversations with their doctors about why they aren't candidates. Now, in some cases, it might be because the cancer has spread to other parts outside of the belly, like the lungs. Maybe it's spread to the liver, which is in the belly, but still outside of the belly cavity, the surface lining. That might be a reason. And if that's the case, then you want to find a systemic therapy. Oftentimes a clinical trial, if you've already had first-line therapy, is your best bet. I think clinical trials should never be considered a last resort. A clinical trial can be a first option, and clinical trials are not necessarily a bad thing. If you think about the COVID vaccine trials right now, that's not a last resort for some people. They want to participate. They want to move the research forward. So don't consider a clinical trial a last resort. But if you have cancer that's considered not operable, then maybe a clinical trial is the right thing. But be specific with your doctor. I've had some people come to me and say that I'm not a candidate for surgery. Now, that might mean that you're not a candidate for surgery that's intended or known to cure somebody, but you might be eligible for a clinical trial that involves surgery, and that's a distinction that you want to get from your oncologist or whoever told you that.
Next question. What's the difference between chemotherapy and immunotherapy?
So just classically speaking, chemotherapy is a class of drugs that are chemical compounds that basically destroy cancer cells. The problem is they also destroy normal cells too, and that's why people lose their hair or have the side effects that you hear about. Immunotherapy specifically is different because it's not, the immunotherapy itself is often not designed to kill the cancer directly. It's designed to activate your immune system to kill it. So one has a direct effect called a cytotoxic effect, meaning it kills the cells, where the other one is, engaging these cells to then go do the dirty work. You know what I mean? So chemotherapy is kind of the classic, that your grandma may have told you about. Oh, I got chemotherapy and it made me feel lousy and I lost all my hair. Whereas immunotherapy is not going to have that effect. It can still have side effects, but not that kind of like kill all the good cells as long as, along with the chemo or the bad cells.
Next question. You mentioned cleft lip. How is that related to stomach cancer?
So what we see in patients, at least with the CDH1 mutation, is that gene CDH1 encodes a protein called E-cadherin, and that protein is very integral to the to embryologic development. So once the egg is fertilized and starts to divide and grow, and the embryo and the fetus develops, E-cadherin function is necessary. If you don't have it, the fetus will never survive. So in the sense that if we do this in a mouse and we get rid of all the E-cadherin, the fetus will never survive. But it's important for formation of things. And one of the things that it helps with formation is kind of midline structures, especially in the face. And so as you're forming as an embryo, things come together in the midline and they kind of fuse. And when CDH1 is lost in some of those areas or cells, it can lead to this midline deformity like a cleft lip or cleft palate. Now, that's because that CDH1 has that function. But why stomach cancer and lobular breast cancer develop as a result of a CDH1 mutation is also related to how CDH1 functions, but kind of in a different way. So they're related because of the gene. not because there's something about a cleft lip and putting you at risk of a stomach cancer. It's because that gene is the unifying factor. And we've been looking at our group here, and we probably have about 15% of our patients in our study have a family history of cleft lip or palate that has CDH1. So if your doctor, and we try to educate doctors out there, if you have a patient with stomach cancer or lobular breast cancer and cleft lip or palate in the family, you need to be thinking about CDH1.
Great. Where are the best hospitals to get treated at? I get this question a lot.
Yeah, I'm not gonna list hospitals. I mean, that would be probably not kosher. But what I would say is this: you want to be treated somewhere where people know something about stomach cancer. You don't want to go somewhere where they're like, oh yeah, we saw this once or twice last year. So go somewhere where they know what they're doing. That's usually going to be a larger medical center or an academic medical center. It's not going to be a community hospital generally. Okay, with that said, when you go, you want to make sure that the oncologist is comfortable and has treated stomach cancer. You want to make sure the surgeon, has treated stomach cancer. And you want to know that those other people that we talked about, whether it's the gastroenterologist, the registered dietitian, are around, available, whatever. And every institution is going to be a little bit different. Every oncologist, surgeon is going to be a little bit different. But you want to have some faith that they know what they're doing. And again, if you go to any major academic medical center, university medical center, or major hospital in a city, you're probably going to be fine. Now, are there programs or places in the country where they treat a lot of stomach cancer? Absolutely. We're one of them, and there are some on the East Coast, the West Coast, and in the middle of the country. But I'm not necessarily saying you need to go to those, but you do need to make sure that the people that are taking care of you, because remember, 27 to 30,000 cases a year in the United States. That's not a lot. By comparison, I think lung cancer, there's something like 240,000 cases a year. So almost 10 times as many cases of lung cancer a year in the United States. Colon and rectal cancer, about 150,000 cases a year in the United States. And now you got stomach cancer that's down here, like only 27, 30,000. So it's not common.
Okay. Next question. Are clinical trials open to residents outside of the US?
They can be. They can be. There's always going to be limitations. We've taken care of people from Canada, the UK, Australia, Mexico. It just depends, because you got to travel, stuff like that. But generally, clinical trials will be open. It depends probably on the institution, but it's something that's not there's no reason to believe that you couldn't or shouldn't look into it.
Okay. Unfortunately, we're out of time for more questions. Please feel free to submit any additional questions to me at programs@debbiesdream.org. Again, that's programs@debbiesdream.org. Dr. Davis, thank you again for joining us and sharing your expertise.
My pleasure. Thanks for having me.
Thank you. I'd like to thank our sponsors once again. Title sponsor, Daiichi Sankyo. Platinum sponsor, Bristol Myers Squibb. Gold sponsors, Astellas and Merck. Silver sponsors, Lilly Oncology, and bronze sponsor, Genentech. To view any of our recorded webinars, please visit our lecture library. That concludes today's presentation. Thank you for tuning in.